So very good afternoon, one and all. I, Aarti Singh, welcome you all in our ISFCP dialogue series. And today we have with us the speaker of the day, Dr. K. Ramakrishna, who is currently working as an assistant professor at KL College of Pharmacy, Andhra Pradesh. His area of research is basically focusing on ischemic stroke, neonatal hypoxic ischemia, Alzheimer's disease. And today, on this day, he's going to deliver a talk on ischemic stroke and neuroprotective strategies. So, we welcome you, sir.
Thank you very much, ma'am. Ma'am, is it my screen is visible to you, ma'am?
Yes, sir. It is visible, sir. Clearly
Okay.
visible.
Okay. Thank you, Aarti ma'am, for introducing me to the ISF fraternity. And in this context, I would like to thank you, the management of ISF, and especially the director, principal, and vice principal, and especially Aarti ma'am for inviting me to give a talk on ischemic stroke and neuroproduction strategies. So as we know that there are some blood vessels running in our brains, which will uh, in our body, which will innervate all the tissues, muscles, and cells in our body. So if there is any impairment in the blood vessels, that leads to that indirectly reflects in the changes in the functions of cells, tissues, organ, and entire systems. The stroke is one of the such kind of disease where if there is a lack of blood vessel, if there is a lack of blood flow to the particular cells, it leads to impairments in cellular activities, leading which are reflected in the functional outcomes. So, according to the World Health Organization, stroke is the neurological dysfunction which is because of ischemia or hemorrhage, which lasted for more than 24 hours or until the death. Therefore, what we see in the commonly in the ischemic stroke conditions, either death or the morbidity, that means impairments in our daily activities or our life quality is going to be decreased if we had the stroke. As per the WHO organization, WHO, the stroke has been majorly categorized into two categories. One is ischemic stroke, second one is the hemorrhagic stroke. Ischemic strokes are the more common type that we see in the most of the cases. More than 85% of the strokes are reported or around the globe or because of the ischemic events like accumulation or like formation of thrombus or the emboli in some of the blood vessels which supply to the brain. In case of the hemorrhagic strokes, we rarely seen at approximately 15% of the stroke that are origin from the brain is of hemorrhagic conditions. Uh, and the ischemic stroke and both hemorrhagic strokes are the fatal if we don't recognize initial times, or if there is any delay in the treatment protocols, then we may see the patients may die, or if we provide the treatment for after some onset of some time, then it causes the long lasting disabilities. So what happens in the stroke and why it is very important? As we know that the brain is the main controlling organ or central organ which will control almost all the body parts in our human system. So why it is very important? Because when there is a reduction in the blood supply to the brain, it leads to, as the blood is carrying oxygen and nutrients, there is a deprivation of these two things. For the cell survival, for the cell any particular activities, these two things are essential so that they can do their work regularly. As we are inhibiting, as there is a deprivation of these two things, the brain cells become deprived of energy and nutrition, then the brain cell starts die, then there is a dysfunction of the brain. As we know that if there is a dysfunction of the brain, so it may be a cortical problem, or it may be logical, or it may be thinking, or it may be any function that will be done by the brain, depends upon the area. So we see the like disabilities. Suppose if there is a stroke in the cerebral cortex, we may see the motor problems most of the times, and the memory issues, and we lose some of the time stability also. In case of cerebellum, we may see walking difficulties, we lose the balance, coordination, and headache we often see. In case of brainstem, apart from cortex and the cerebellum, if we have the brainstem stroke, it is a very fatal because it has some of the crucial centers which regulates the function of heart as well as the lungs. So any damage happens because of the stroke in the brainstem is fatal more than any other regions of the brain. How do we identify the brain? So stroke, the brain stroke after an event of stroke, so we see whether we had a stroke or not on the based upon some of the symptoms. Suppose we have the balancing difficulties, we may see the double vision, and some of the patients experiences difficulties in swallowing due to motor problems and dizziness, numbness, loss of coordination, and difficulty in articulating words, vertigo. So therefore, to recognize the stroke and its symptoms, so the world is following one of the code, that is the FAST. So this code represents facial abnormalities, F indicates facial abnormalities, A indicates arms deficiencies, S indicate speech, and when you see all these events, problems in the face, arms, and speech, it is the right time to call ambulance, or we should hurry to the hospital so that the patient will be getting will be getting initial treatments. So all over the world, like in global and Western countries, they immediately call ambulance by calling to the 911. So whereas in India, some of the states have uses the code, that is 108. It is well known in most of the states. So if you see any of these symptoms persisting for longer time, so we should call, or some of our family members should call to the 108, depends upon the state availability, then you will get immediate attention. And why we should bother about the stroke? Okay. If you see the stroke, apart from the cardiovascular events, stroke, especially the brain stroke, is the one of the second leading causes of death around the globe, not only in India. And every 2 seconds, there is a person affects from the stroke. Every 6 seconds, there is one death around the globe, and the case fatality rates approximately 24% in the cases of urban, and 37% of in case of the rural population. So we'll see why there is more fatality rate in the case of rural conditions than the urban conditions. And among 1 by 6 of all the human beings, at least in their lifetime, there is a stroke happening in their body, but we did not understand, or we did not able to identify whether it is a stroke or not. But in persons, everyone lifespan, we may face a stroke. And this is the recent data about stroke in 2019, which is given by the World Health Organization, and combination with AHA and ASA, American Stroke Association and American Heart Association. Approximately 77.19 million people are experiencing the ischemic strokes. Among them, 63.48 patients having the impaired quality of life, and approximately 3.5 million deaths are reported around the globe. When it comes to the India, per 1 lakh populations, there is approximately 150 of them are going to get the strokes. There are prevalence rates are there, and 40 to 40.3 to 560 approximately in the 1 lakh populations, there is a prevalence rate. And as this data is derived from the 2019, and approximately the statistics may be varied, so there may be an increased number of ischemic stroke conditions. So we can see, and we can compare here the global and the Indian status. So approximately in India, 1.4 to 1.6 million per new cases here, and approximately 0.6 million deaths. So there is a lot of burden, global burden, and the Indian economical burden is there on the Indian countries, and and also on the globe. So what are the risk factors that causes stroke? The stroke can be caused by there are three major risk factors which can stimulate stroke in a person, which are categorized into three categories: controllable, controllable, and lifestyle factors. The controllable factors includes high blood pressure, coronary artery diseases, high cholesterol, like diabetes and atrial fibrillations. Whereas uncontrollable, age, gender, race, if you had any family history of transient ischemic attacks, or the personal history or family history of the diabetes, so there is a chances of getting stroke in the later stages. And lifestyle factors, if you have an habit of smoking, alcohol, if you are obese, if you are not following regular exercises, or if you are not doing physically active for longer hours, so you may have the chances to get the stroke. As we understand, these factors enhances the stroke. So thereby, if we avoid some of the factors, we can avoid, like smoking, alcohol, or the bp or diabetes, so we can avoid up to some extent. But if there is a chances of genetical problems issues, then we cannot control them. So you can see the below statistics. The most of the stroke patients, out of 10 patients, approximately 10 patients die because of the early intervention is not provided in terms of antihypertensive agents. If a stroke person has admitted to the hospital, if we don't recognize instantly whether the patient is having hypertension, if we detect the hypertension in the patients, if we could provide the antihypertensive treatment initial conditions, so we can save approximately 10 persons who had this stroke. And among them, more than 65 aged people, more than who crossed the 65 years old age. So at least we can save them if we can stop them smoking, or if we can stimulate them to not smoking, so that we can prevent the stroke attacks in the elderly people. So this is the protocol most of the times, approximately, like in around the globe or in India or anywhere they follows. This is the pattern, or this is the way we have to shift the patients, or these are the time periods where we have to shift the patients from hospital, from the home to hospital after an ischemic stroke event. At least we have to bring the stroke patients within, do to doctor at least 10 minutes. Then access to the neurological expertise, it will take approximately 15 minutes to diagnose whether the patient had stroke or not. Then we have to confirm from the neurological examination to either MRI scans or CT scans. Approximately, it will take 45 minutes, and initiation of treatment for the stroke patients will start after 60 minutes, and admission into the stroke unit for approximately 3 hours. If we can administer the person within 3 hours in the hospitals, then only we can save the patients. So there is a reason for that, because whatever the drugs that we have in the market or in the clinics can have the ability to show its activities if we had administered the patients within 4.5 hours. And okay. But when it comes to the Indian scenario, so why there is more prevalence rates or more stroke deaths in India compared to other countries? Because we have these non-availability of some of the conditions, like there are no 24 into 7 stroke physicians are not available. Sorry, and stroke interventionalists are very less in India compared to other countries. Stroke area maps means which country, or sorry, which states or which districts in India have the more number of cases of strokes. So there are no maps, has not been identified by the Indian government. And stroke care pathways. Suppose if the person has had a stroke, so we have to get immediate attention or immediate treatment to them. For that conditions, we have to create a care paths in urban, or in the case of like rural population, so that we can save them. Stroke units is not available. The stroke teams is not available. But currently, the government, with the help of ICMR, is in every state. It is almost recruiting some of the staff. They wants to train so that we can save the stroke patients. Maybe it is an heart stroke, or it may be a it may be a brain stroke. And sufficient community awareness programs are not being held by the government and or from any NGOs or extra, and efficient public emergency ambulance systems are not available. That is the major problem. So as I told that we should administer the patients within 3 hours, so that we can get some treatment for that patients. So due to non-availability of ambulance services, and therefore, and most of the stroke care centers are located in the major cities, where the maximum population is there. If the person is almost 100 kilometers away from particular city, if he wants to get the treatment for the stroke, so almost it will take around 2 to 3 hours to reach hospital. In that sense, almost half of the brain or half of the stroke area got damaged, and we cannot save the patients. So all these scenarios, in particular to the India, is limiting the therapies and to get the immediate attention for the stroke patients. What are the challenges that we are facing from the patient sides? The patient is unable to judge whether he has a stroke or not, because and the overpopulations. So as we understand that the overpopulation, as we don't have the so much stroke interventionist or neurologist particular to the stroke. So if we had number of stroke conditions, so we the doctors or the clinicians may not give 100% time to them, one of the problems. And mostly the patients will delays to contact the doctor. So these are the hurdles we have to overcome if you want to get very good treatment for the stroke patients. And how do we treat the stroke patients? So there are two major therapies for the ischemic strokes, not the hemorrhagic strokes. So these are the two therapies. That is reperfusion. When we have a major artery block, which supplies to the brain, maybe internal carotid arteries or vertebral arteries or external carotid arteries or internal carotid arteries. So we can break that clot by using the thrombolytic agents. And second one is, after we had a stroke, if we use any thrombolytic agents or antiplatelet or antithrombotic agents, so we have to preserve, or we have to protect the area that is damaged because of the stroke event. So you can see here in the red color, it is an ischemic event exactly after a blood vessel block. But the blue area indicates there is a chances that other areas of the or surrounding areas or vicinity area of this that stroke also getting damaged. So the early interventions, that is the reperfusion, will be used to block that red color area, whereas the blue color representing area will use the neuroprotective agents to block further extent of the disease damage. So the reperfusion we can be achieved by using the thrombolytic agents, which are widely used in the clinics, antiplatelets and antithrombotic agents. The primary therapy for treating the ischemic stroke is the thrombolytic agents, whereas antiplatelets and antithrombotics we use in the primary cases and also for the prevention of reoccurrences of the stroke. So basically we see the administration of antiplatelets and antithrombotics for diabetics and stage diabetic patients and hypertensive patients, so that they will not get any stroke. Yes. So far, we have only one drug that is approved by ESFDA, that is the tissue plasminase activator. So we commonly call as an altiplase in the general terms. And moreover, this drug is not approved by all over the world. It depends upon the bench to clinic to clinic. Some of them may use or some of them may not use because of its narrow therapeutic window. So we have to administer the patients within 3 hours. He has to get treatment within 3 hours. That is the criteria, because this thrombolytic agent only shows the activity, better activity in up to 4.5 hours. So it has a narrow therapeutic window. If we initiate the treatment with this drug for more than after 4.5 hours or 6 hours or 7 hours or 9 hours, so we may not get the effect because of its narrow therapeutic index. As I said, that this drug is not approved in Europe, South Asia, and Australia. So getting the treatment in those countries is majorly they'll go for the thrombectomy, means surgically they remove the clots. And some of the cases, if the patient is not suitable for either thrombolytic agent therapy or thrombectomy, so the doctors, clinicians suggest to use drugs like aspirin and clopidogrel, and sometimes in the combinations they use. But however, using these drugs have some side effects like they causes gastric bleeding, and some of the anaphylactic reactions also reported in the clinical conditions. Approximately in the clinic so far from the 1995 to 2015, approximately 430 drugs were studied in the clinics in the clinical trials, but we have approximately 20 drugs approved around the globe. Some of them for treatment, some of them for prevention. Okay, suppose if you see the thrombolytics, that it is intravenous tissue plasminogen activator, will be particularly used for the treatment, not for any prevention purposes. So we have to use, we cannot go for more than 90 mg of 90 milligrams of dose per day. We cannot use more than the dose for the stroke patients. So antithrombotics and antiplatelets, if you see the agatroban, which is used for the treatment, not for the prevention purpose. Dabigatran, apixaban, edoxaban, all these antithrombotics will be used for the prevention. And antiplatelet, if you see, there are two drugs majorly used for the treatment purpose as well as the prevention purpose. Like clopidogrel and aspirin are widely used for the prevention of secondary strokes than the primary strokes. And apart from that, there are neuroprotectants that are being used widely in the clinics, like zinco, fascidil, cerebrolysine, cortisol, and edaravone. So the edaravone is widely all over the globally. It is approved as neuroprotective agents for a stroke. As per Medical Association and Medical School Association from the 2003 data, so there are some conditions, and as recommended, how do we avoid the patient had to the hospital, so you know, yeah, therapy is the mechanical one. If we surgically remove the clots or emboli, if we initiate the RTP and the mechanical thrombectomy, we can treatment within 4.5 hours. If the patient is not responding to the RTPA, in that sense, we can go for the mechanical thrombectomy easily. Whereas in this RTPA, we have to administer this drug in 4.5 hours. And if the patient is usually intravenous RTPA, we cannot administer aspirin because both drugs causes the deprivation of the one drug causes the platelet inhibition and the thrombotic events. One drug is breaking to thrombotic already formed thrombus. So in that sense, what we do is we use these drugs to reduce the hemorrhage formation. It has been reported that if I administer aspirin on the treatment like treatment antiplatelets, so there is a chances of increased hemorrhage in the platelet. So thereby, we are instead of save the patients, we are put the patient under more stressful conditions. And what are the problems or what are the shortcomings of the current therapy? RTP cannot be more than beyond 4.5 hours. And there is a risk of interstitial hemorrhages, low efficiency. Suppose if I want to treat a stroke which had because of the larger size arteries are blocked. So in that sense, this RTP is something we do very well. And angioedema, anaphylaxis, fever or other side effects of these drugs. Whereas in the case of people want to use aspirin, in the relief factor. So in that sense, there are some limitations. And if the person is having all these problems, we cannot administer artificial or aspirin. In that sense, we have to go for the complementary substitute. So coming to the neuroprotective strategies, as I told, especially we cover the ischemic stroke and its pathology and the neuroprotective strategies. Why should we should correct the movements? You see this cascade, an ischemic cascade, basically for after following a stroke, there is an oxygen glucose deprivation, and there is an immediate iron imbalances that leads to the activation of NMDA and parasympaths and the rapid influx of calcium into the cells that leads to the depolarization of the key structure, that leads to the RBS generation, RNS generations, and apoptosis events happens. So, following this stroke, due to deprivation of oxygen and glucose, so there is a activation of ischemic event, that is apoptotic pathway on one side, and another side there is a necrotic pathway activated because of the release of MLPs or because of the inflammatory markers, because of the GBB modernization. So altogether, after following an ischemic event, apoptosis and necrosis simultaneously work they instantly in the brain cells. As we learn that the brain has no energy sources, the glucose deprivation is very critical factor for determining the of human cells. As like other cells in the body, they have some reservoirs for the energy, whereas in case of brain cells, they continuously depends upon glucose. So with any deficiency in glucose or oxygen, we see the apoptosis as well as necrosis occurring without chemistry. So there are several pathways are involved, and as we done that approximately more than 500 drugs were studied in the patients, but we have only 20 or more than 20 drugs, it's approximately 20 drugs are there. So what is exactly the neuroprotection? You can see in this image that in the first image indicates that there is a red light, red dot indicates that it is a stroke because of the formation of thrombus or an embolism. The blue area indicates exactly this is the area we call as the core area. Ischemic core area in terms of stroke terminology, we say here. Ischemic core area where exactly the blockage of the blood vessel which supplies to the particular area is going to be affected primary. When we don't give any treatment, a yellow color in the bottom image indicates spreading of the infection or spreading of the skin is going to affect other parts of the body. So basically, this process, the skin, the core area will be approximately 24 hours to 48 hours. We see the core area cells are going to die, and if you see there is no treatment of the that neuroprotective agents or anything that agents. Almost one of the hemisphere of the brain is going to get affected. That means we see one half of the hemisphere of the brain is not going to work. So it clearly impacts the functions of the hemisphere. So we that is affected that paralysis or speech problems or vision. Sometimes it becomes common, but also. What are the challenges?
Sorry, sir, for interruption. Your voice is like very low. It is coming very low.
Okay, sorry, sir. Then I will use.
Yeah.
Now it is okay, ma'am? Yes,
Sir, can
ma'am.
you please repeat?
My voice is okay now. Is it audible?
Uh, Now it is okay.
Okay.
Yeah.
So you can see that core area, if we don't protect the core area or if we don't preserve the core area, then there is a deficiency in the mineral area. That means the function of this even remains that to the other part of the brain is becoming the complete blockage of the hemorrhage. So the chances of complete blockage of one of the hemisphere. How do we protect? How do we protect that? What are the challenges that are there preserving the core area and receiving the so far we have tried with antioxidants, we have tried with anti-inflammatory drugs, blockers, calcium channel blockers, and MMP9 blockers, lactic acid.
Sir, your voice is not coming.
Hello?
Yeah.
Yes, ma'am. Is it audible, ma'am?
No.
Ma'am, is it audible?
Yes, now it is okay. Much better. Much better.
Okay. Sorry, I'm moving to backslide because this core area we have to preserve, we have to protect because whatever the damage happens to the core area, most of the times we cannot recover. But what we can protect is we can protect the yellow color area that is we call as a penumbral area to prevent further loss of the neurons and its functions. So there we have tried many approaches like we have used antioxidants, we have used like anti-inflammatory drugs, we have used calcium channel blockers, MMP9 blockers, and we tried all the pathological events that triggers the ischemic cascades. Like we have used anti-apoptotic drugs, uh, so that but still we are lacking the effective neuroprotective strategies. And approximately around the globe, only the one drug that is Adaravone is widely used as an neuroprotective agents for ischemic stroke as well as other disease conditions. So therefore, there is a lot of there is a need of more neuroprotective agents, with, so that we can preserve or we can alter the quality of life. We can improve the quality of life in the ischemic stroke patients. And there are some challenges that we need to overcome from the preclinical point of view and clinical point of view. When it comes to the preclinical point of view, so in experimental conditions, we mimic the stroke conditions in the rats or mice or some of the gerbiles or and the species. But when it comes to the clinics, there are some certain differences are there between the animal models and the human models. Suppose if I say if we choose a rat or a mice, compared to the comparatively the humans, there are less number of neurons are present in the mice and rats. And whereas in case of the humans, there are more number of neurons in their brains. That is the leading factor, because we don't know and we are not expected that how many neurons are going to die in the human conditions, and we never know how many number of neurons are going to dead in the case of animal models. So if we can overcome, or if we have better animal model, so that we can mimic the human stroke conditions in the animal. So, but however, this is highly impossible because we don't have sufficient models, sufficient preclinical models to mimic the human stroke conditions. And when it comes to another point, when it comes to the like the model that we choose to study the neuroprotection. Suppose if I had a drug that is antiplatelet or antithrombotic drugs, so I cannot use the model that is MCO. Basically, in the preclinical studies, we use middle cerebral artery occlusion model. That model has the validity, some of the validity. That means it can only be just, we can study the neuroprotection, not for antiplatelet or not for antithrombotics or not for like thrombolytic agents. So in that sense, if I want to study some of the drugs like antiplatelets or antithrombotics or thrombolytics, I have to create a thrombus or I have to induce an embolus in the animal models by using endothelin or the rose bengal dyes or ferric chloride or kerosene thing. So the selection of model in the preclinical studies are very important to mimic the human conditions too. So there are some challenges why we don't have the effective neuroprotection in the clinics. The major challenge is the delay in the initiation of the treatment. As I said that almost when you reach hospital within 3 hours or within 2 hours, there is a damage happens in the core area cannot be recovered. As we know that the neurons are irreversibly damaged. So there is no reversibility. So there is no regeneration process. So whatever the damages happen, so we cannot preserve that areas. By the time we made diagnosis in the clinics, almost all the like damage is proliferative. That means it spreads to the other areas. So the areas, as much as early you reach the hospital, you will get the initial and a better treatment. And second most important, as we studied several kind of neuroprotective agents, they have the broad spectrum of activity. That means they inhibits multiple pathways. When a single drug is inhibiting multiple pathways, we see, apart from the protective effect, we may see a lot of side effects. This is this is possibly applied to the neuroprotective agents. Suppose if I see the RR1, it exhibit antioxidant effect. It can inhibit anti-inflammatory effect. It can cross the, like it can have some effects on the blood-brain barrier. So in that sense, if I want to use that particular drug, I expect some of the toxicities because it is targeting multiple events in your brain cells. So this is the one of the limiting factor. And third one is selected dose. When it comes to the preclinical studies, the effective dose may not shows very good activity in the like human studies. So we have to extrapolate the dose that we get from the preclinical studies to the clinical studies. So in that sense, we may not get the same effect like we did see in the preclinical studies than the compared to the clinical studies. And the route of administration, as we see, the most of the times we may use the drugs through the oral route, or intraperitoneal route, or subcutaneous route, or intravenous route. But whatever the dose you are choosing for the preclinical studies, that that route of administration may not possible in the concept in the cases of clinical studies. So you have, sorry. So we have to choose effective dose, and we have to try all the which is the best effective dose in possibly in the case of mice or rat with the different routes of administration in order to, so that we study the pharmacokinetic parameters effectively. And the fifth point is about the stroke or any of the neurological disease is the combination of environmental factors, genetic factors, and life factors. So when it comes to the preclinical studies, or like in the laboratory conditions, we may stick to environmental factors or genetic factors or life factors, not by all these together. So, in that sense, if I use a neuroprotective agents, so it may particularly change lifestyle or genetic or some of the protein content or DNA content. So, in that sense, it may not alter all these three events. So, there is a chances of failure of all the components into the drug. Suppose if the drug is not if the drug is not crossing the triple B, then we may not get adequate protective activity, as though the triple B is compromised in the ischemic stroke conditions, we may get the activity, but if the drug has no inherent property to cross the triple B, so it may not be used for the preventive purposes. We can use for the treatment purposes, but we may not use the drug for the prevention purposes. And the next one is the major point that we are almost all the neurological scientists are bothering about the irreversibility of the neurons. Once the neurons are damaged, they cannot be regenerative. They cannot be regenerative, but still some research is hoping that for like Alzheimer's and Parkinson's disease, they are identifying some of the neuronal outgrowth or neuronal growth after giving some of the treatments like DBS, like deep brain stimulation and extra. So we expect we would have a better drug which can stimulate, which can stimulate the neuronal regeneration properties, so that we can regain the quality of life, we can regain the neuronal intact structures especially. And as I told, the selection of preclinical model also very important. We cannot choose a wrong model. So if I want to study the neuroprotective models, I should go for the MCO model. If I want to work on, if someone has to choose like platelets or thrombotic events, then we have to go for endothelin or rospengol or ferric chloride models, so that they'll induce a thrombotic event particularly in case of the brain arteries. And apart from treatment, apart from the treatment, the nutrition that we provide to the stroke patients, the food that we provide to the stroke patients also very important, because as we learn that the food is medicine every time, right? If we take right food, that is the right medicine for them. Okay. So for the stroke patients, there are some recommendations given by the American Heart Association and the American Stroke Association. If the person had a stroke, he has to eat a fresh foods, and he can include some of the grains like oats, brown rice, barley, legumes, beans, peas, oily fish content, salmon fish, and they can highly recommend you to take unsaturated fats, not saturated fats, and the yogurt and skim milk, nuts and seeds, so that they are easily digested in our body, and they are very nutritious. So therefore, the food after a stroke event, after a discharge from hospital, also determines the condition, also determines the neuroprotection. So itself, the food has a lot of rich phytochemicals or some of the medicinal values, so that they will protect the brain from the ischemic event. And what are the foods that we cannot consume after a stroke event? Suppose I cannot consume, or I should avoid the foods that are from the bakeries, like baked goods, breads, cakes, pastries, are very harmful for the stroke patients especially. And if the food consists of saturated fats, I should not go for that kind of foods. Red meat, red meat, if I choose like mutton or beef or pork. So there has been several clinical indication studies reports that those persons who takes red meat following a stroke event increases the ischemic events, cardiovascular events, in like cardiovascular abnormalities in those patients. And the brown sugar and the molasses and high salty content foods cannot be taken. So though we give the treatment like neuroprotective or primary therapies, but if we are not following the food, if you are not taking the right food, that again causes the secondary, there is a chances of secondary stroke. So with this, I want to conclude it that like the ischemic stroke may happens at every time, because we have no advanced technology to predict when we are going to get the ischemic stroke. or any other neurological disease. Suppose if we want to get Alzheimer's, if I want to see, if I want to get a treatment for Alzheimer's or Parkinson's, I have to wait for 15 to 20 years so that the symptoms may appear. Then I will come to know that there is a Alzheimer's or Parkinson's to me. So similar to some like those conditions for the ischemic stroke patients, there is no particular biomarkers in the case of like ischemic events. So what I can do, or what we can suggest, the persons who have hypertension or who have the diabetes, they are the high they are the highly prone to get ischemic strokes. In that sense, like using antiplatelets or antithrombotic agents or reducing the prevalence rates in the cases of ischemic stroke. So apart from, as we know that these thrombolytic agents and antiplatelet and antithrombotic drugs only will be used for the primary treatment. So in the secondary treatment, we have to depends upon the neuroprotective, because we have to preserve, we have to improve the quality of life, we have to improve the person daily activities, so that he is not depends upon the others. It will reduce the burden on him and his families. So in that sense, only the way we can achieve this is because of using the neuroprotective agents. So there are approximately 20 neuroprotective agents are there in the clinical trials, and about 5 to 6 compounds are in the fourth phase of the fourth in the fourth means third phase. They're about to complete the third phase of clinical phases. So we may get more number of neuroprotective agents in maybe in coming 5 to 6 years, so that the treatment can be reached for almost all over the globe with multiple options. And I would like to thank to the KL management for giving this opportunity and facilities to conduct my research over here. And especially I thank to Dr. Arti ma'am for her help in submission of my recent proposal for this cell. And I also thank to like all the management of ISF for giving me these opportunities. So it's open for discussion. Any doubts, if you have any questions, I can answer happily. Yes, ma'am.
Ma'am, am I audible? Your voice
Yeah,
is not
yeah,
audible.
yeah, audible. So
Thank you.
thank you very much, sir, for your valuable talk on ischemic stroke and therapeutic approach. And I hope the knowledge shared by you will definitely help the young brain to think on the research topic on the stroke. And we
Yes.
really thank you very much for accepting our invitation, and we really appreciate your time and effort, sir. Thank you once
Thank you.
again. And once this lecture is uploaded on the YouTube session, I will share the link with you.
Okay, ma'am. Okay.
Yeah.
Thank you. Thank you, ma'am.
Thank you very much, sir. Thank you very much.